Okay, my name's Deborah, and I'm a myeloma nurse in Tasmania, and Tash resides in Queensland, who's also a myeloma nurse. Right, better put my glasses on so I can read. So just a few things before we start. The toilets are just outside on the right. There's tea and coffee. There's gifts on the table to buy that you can use your credit card. There's caps and tea towels, socks and T-shirts. There will be time for questions after each speaker, but please be mindful that we are keeping to a time schedule. If anybody would like any more reinsurance or info, you can search one of us out. We're all in the red and the white T-shirts. There are feedback sheets on each table, and there's a QR code or a link to go to a short survey. If you would kindly do that, that would be great. There will be photographs taken today. So if you do not want your photo published in social media, just let us know. And there was one last message that if someone has lost a parking ticket, if you find out that it's you, it's at the front desk. All right. So our first speaker today is Professor Hung Quach, who is the Departmental Head of Clinical Haematology and Clinical Haematology Research at St Vincent's Hospital in Melbourne and Professor of Haematology at the University of Melbourne. She is passionate about increasing the therapy options for patients and ensuring access to the most effective treatment that may not otherwise be available to Australians. And she has secured funding of more than $14 million towards myeloma research and is highly published in the field of myeloma. In addition to her role as co-chair of the Myeloma Working Group of the Australasian Leukemia Lymphoma Group, Professor Quach also serves as the Deputy Chair of the Myeloma Scientific Advisory Group for Myeloma Australia and has active roles in steering committees of a number of other national as well as international healthcare bodies. So I will now hand you over to Professor Quach, who is going to speak to us about MGUS2 myeloma.
Thank you, Deborah. Thank you. I'm so honoured and humbled to be here, and my heart just stopped when Sandy mentioned about me hugging someone because I'm still waiting for that call from HR. Hasn't come yet, but I'm just grateful for the opportunity to vent my emotions when I need it. So for those of you who know me, it's all out there. So my job is to talk to you about MGUS2 multiple myeloma, and it's just an overview because Dr. Angie Yong and Dr. Cindy Lee will then talk to you about treatment options later on. But I want to start off on a positive note. And that is there has been a significant improvement in survival for people with multiple myeloma over the recent decades. So back in the 1990s or before the 1990s, the average survival for people with multiple myeloma is only less than 2 years. And that was the era where we only had chemotherapy. And then come the 1990s to the year 2000, we then introduced autologous stem cell transplant. And for the first time, there was improvement in survival for myeloma in the order of about 3 to 4 years. And then at the turn of the century, we then introduced new groups of drugs, the immunomodulatory drugs or the proteasome inhibitors. And some of you might be on these agents now. And these agents improve survival for people with multiple myeloma in the order of 5 to 6 years. So currently, the median survival for people living with multiple myeloma around the world is in the order of 7 years. That fact being said, this is where we are heading. We are heading to an overall survival in excess of 20 years, and we are now starting to talk about the concept of operational cure. Operational cure means you live with the disease, but the disease does not progress, so you end up passing away from something else altogether. And that's due to the number of overwhelmingly effective therapeutic agents, including immune therapies, which you'll hear a bit more about later, and small molecules. And the improvement in survival is very important because the burden of myeloma is set to increase around the world, including Australia. So this here is Australian data. Whoops. So here you go. This here is Australian data. On the left, you can see that the incidence of multiple myeloma is set to increase and is increasing over the years. The orange line represents men, the grey line represents women. I don't know why myeloma is more common in men, but it is. But the incidence is increasing. On the right-hand side, you'll see that the 5-year survival rate is increasing each year. Now, with an increasing number of patients being diagnosed and each patient living longer, you see the burden of myeloma is set to increase in Australia, and this is why it is so important that public awareness is improved. So what is multiple myeloma? I'm sure you all know what it is already, but just to reiterate, it is a cancer, a blood cancer, involving a type of immune cells called plasma cells. These plasma cells are normal cells that produce antibodies to fight infection. That's their normal job. But when they overgrow in the bone marrow, they then produce abnormal antibodies. And these abnormal antibodies are the antibodies that they are called paraprotein or M protein, and we can usually detect them in the blood. And there are various types of paraproteins, so a person can have IgG multiple myeloma, IgA, or less commonly IgD. And there are some people with multiple myeloma that only produce a component of the antibody called the light chain, as you can see there. I can't point because there's no laser here. But the kappa light chain or the lambda light chains, and so they are called light chain multiple myeloma. And if these paraproteins or light chains are present in the blood, we use them to monitor how your disease is going. So say if a person has multiple myeloma and we don't do anything about it, what happens? Well, what happens is end organ damage. So these myeloma cells, by virtue of producing various hormones or cytokines or chemicals in the body, they can eat away at the bones, causing bones to become weak. So the lytic lesions get holes in the bones and the bones become weak, and you can get fractures with very minimum trauma. And as the bone is damaged, calcium is then leached out of the bone, so you can have high calcium in the blood, and high calcium can cause various problems, including fatigue, tummy pain, tiredness, and at the very severe end, you get confusion, you get kidney failure. And of course, the kidneys are very prone to damage in multiple myeloma because the light chains that I mentioned are quite toxic to the kidneys. And these myeloma cells also actively suppress other immune cells. So a person with myeloma can be quite immune suppressive and prone of getting infections. And finally, when these myeloma cells invade the bone marrow, they leave no space for good cells to grow. So a person can have low red blood cells, that's anemia, low white blood cells leading to infections, and low platelets leading to increased risk of bleeding. Now, we also know nowadays that all myeloma would have proceeded from a pre-malignant, pre-cancerous condition called MGUS, M-G-U-S. This is monoclonal gammopathy of uncertain significance. So what is MGUS? MGUS is a situation whereby you have a population of abnormal myeloma cells, and these abnormal myeloma cells produce the abnormal paraprotein that we spoke about. But yet they're not growing, they're sleeping. And because they are not actively growing, they are technically not cancer. You'd be surprised to know that this is quite common. 5% of people over the age of 55 around the world have MGUS. And these MGUSs, they lie there, they don't do anything, they don't cause any end organ damage, so there's no myeloma-defining event. With time, these populations of cells may grow, and they can occupy more than 10% of the bone marrow, and this is when they are multiple myeloma. Now, just because they're growing, meeting the criteria for myeloma, it doesn't mean that they are awake. Sometimes they can be relatively quiescent and still asleep, in which case they are called smouldering multiple myeloma. Smouldering multiple myeloma means you've got the myeloma, but it's not causing you any harm, it's not actively growing, well it is, but it's slow, and it's not causing any end organ damage, so there is no myeloma defining event. And then with time, a proportion of these cells may grow, and a proportion of patients may then develop overt multiple myeloma, aka symptomatic multiple myeloma. And this is when, if we don't do anything about it, the person goes into trouble because there is end organ damage because the myeloma is actively growing. And then there are a proportion of patients in whom the myeloma cells leave the bone marrow, goes into the blood, and this is very aggressive. Now, upon progression, Not everyone with MGUS progress to multiple myeloma. There are some people with MGUS who then progress to other blood cancers, including lymphoma, CLL, chronic lymphocytic leukemia, or amyloidosis. But the majority do progress into multiple myeloma. The risk of MGUS going to multiple myeloma is in the order of 1% per year, and the risk of smouldering myeloma progressing to multiple myeloma varies because this is a very diverse group, and the risk is calculated based on a risk score, which I'll talk a little bit about later. Now, what causes MGUS to then progress to become smouldering and then multiple myeloma? Well, the first thing to say, it's nothing that you can control, so don't go blaming yourself. But it's based on 3 factors. The first factor is there is an increasing abnormality in the plasma cells itself. So as you can imagine, these plasma cells, when they divide, the subsequent generations may harbour more and more abnormal genes. These are not the genes that you've inherited from your parents, or will you pass it to their children. These are the genes in the myeloma cells, and these genes confer survival advantage to the multiple myeloma. And then the second abnormality is within the bone marrow. See, these guys, they grow within the bone marrow. And in the bone marrow, there's like a fertile microenvironment. The fertile soil in the bone marrow is conducive for the myeloma growth. And the third thing is there's progressive immune dysfunction. Now, our immune system is the most powerful tool we have to keep the myeloma or the MGUS under control. But as the immune system becomes more dysfunctional, the myeloma may escape detection from the immune system. And later on, when you hear about treatment, you'll hear that the treatment will address each and every of these aspects of abnormality. Now, as I mentioned, MGUS and smouldering myeloma are the stages preceding multiple myeloma. So what's the difference? So this curve here shows the risk of progression to multiple myeloma. The bottom line represents MGUS. So if a person has MGUS, the risk of progression to multiple myeloma is 1% per year. It's quite stable, and you can see there at 10 years, the risk of progression to multiple myeloma is only 10%. So 90% of the time, you'll be fine. It's a bit different with smouldering multiple myeloma. That's the top curve. This is a diverse group of patients, and the risk varies. You can see that the risk at first diagnosis is highest. That is, the risk of progression to multiple myeloma is in the order of 10% per year. And then after 5 years, if a person with smouldering myeloma does not develop myeloma, then the risk decreases. The proof is already in the pudding. You know, the risk decreases to 3% per year. And then after 10 years, if a person with smouldering myeloma does not develop myeloma, then clearly he or she is behaving like an MGUS, even though it looks like a smouldering multiple myeloma. Now, there is a subgroup of people with smouldering myeloma who we would call high risk, and high risk being the subgroup of people with more than 50% chance of developing the end organ damage I spoke about, or multiple myeloma, within 2 years. Why is it important to recognise these people? It is because there is now active research to see whether we should address or treat these people earlier before they develop multiple myeloma. I mean, why wait until you address things? And so it's a complex slide here, but the bottom line is the way in which we identify high-risk smouldering multiple myeloma is based on 4 parameters. The only reason I'm talking about this is you can start to hear more and more about it because I think the field is now going to change to earlier treatment. So it's based on, number 1, the light chain, the level of light chain in the blood. Number 2, the level of paraprotein I spoke about. Number 3, the level of the degree of myeloma cells in the bone marrow. And number 4, the genes. Not your genes, the genes of the myeloma cells. And based on this risk score, we can calculate and divide people with smouldering myeloma into 4 groups. The first group are the low-risk group. These people behave like an MGUS. The risk of progression to multiple myeloma in 2 years is only in the order of about 3 to 4%. The second group, low intermediate. And in this group, only about 1 in 4 people progress to multiple myeloma in 2 years. The third group is a slightly higher risk, the intermediate risk group. That is, 1 in 2 people will progress to multiple myeloma in 2 years. And the fourth group is the high risk group. In here, 3 out of 4 people will progress to multiple myeloma in 2 years. And it is in this group of people who we're thinking, maybe we should do something a bit early. We shouldn't just wait until, excuse my language, shit hits the fan. So we should really address it beforehand. All right, but I want to stress, don't jump and demand treatment, because until further data is obtained, the current approach for people with smouldering myeloma, including high risk, is to watch and wait. But watch this space, because I think it's about to change. So what then defines multiple myeloma? Currently, we wait for end organ damage to happen before we treat. This is myeloma defining event. So you can remember it by the acronym CRAB. C stands for high calcium. R is renal, kidney damage. A stands for anemia. B stands for bone lesions on X-ray, the CRAB features. But nowadays, in people without the CRAB features, there are characteristics that can predict a 90% risk of developing the end organ damage within 2 years. And now we call these people myeloma as well. So what are these features? The first, the degree of myeloma cells in the bone marrow. So 60, if more than 60% of the bone marrow is infiltrated by myeloma cells, that's a myeloma defining event. We treat irrespective of presence of end organ damage. The second is the level of light chains. If the light chains are really high, kappa or lambda light chain ratio more than 100, that's another indication that we should treat earlier. And finally, MRI. And there are some people who have no bone lesions at all on CT scan, but MRI are more sensitive. So if we can find more than one lesion, i.e. at least two, on the MRI, then that's an indication that maybe we should treat these people a bit sooner. And so just to summarise, the new diagnostic criteria for myeloma are the CRABs and the SLIM CRAB. So SLIM CRAB, S for 60% of bone marrow, LI, light chain, M for MRI. So that's what we teach our medical students. Now, Dr. Angie Yong and Dr. Cindy Lee is going to talk to you about treatment. So I'm going to paint a picture to talk about how myeloma develops, just so you can have a bit of perspective of where all these treatment lies. So you recall that I said that myeloma starts within the bone marrow. And when these guys become cancerous, the first thing they do is they develop sticky molecules on their surface, and the sticky molecules allow them to bind to the bone marrow. And when they bind to the bone marrow, there's now a communication. They then produce growth factors to establish for themselves a very fertile microenvironment to grow. The microenvironment, the so-called bone marrow stroma, can then produce blood vessels that can bring blood and oxygen to feed the myeloma cells. They also then produce growth factors to feed the myeloma cells as well. So you now see a symbiosis, a vicious cycle where you've got myeloma cell growth producing fertile soil, and in turn so on and so forth. Now, when myeloma develops, what's supposed to happen is that we have an immune cell called antigen-presenting cells. These are like your police patrol that patrols the streets, the dark streets. And these cells are supposed to recognize any cancerous cells, including the myeloma cells, and eat them up. And they're supposed to present bits and pieces of them to the headquarter immune cells called the T cells. And these T cells, now recognizing the myeloma cells, is supposed to call on a whole host of immune army to come and kill the myeloma cells. So this is what we call anti-myeloma immunity. This is what keeps it all under control. But you see, the issue with myeloma is these cells are very smart. They produce on their surface various proteins that can block the function of the headquarter T cells. They can produce all the cytokines or enzymes or chemicals that can downregulate the function of the natural killer cells. And so overall, you can see that the immune is quite impaired in multiple myeloma. And therefore, there are three areas of pathology in myeloma: problems in the immune system, problem in the fertile microenvironment, and problem within the myeloma cells itself. And so therefore you can see in the olden days all we had was chemotherapy. And all chemotherapy did was kill the myeloma cells. It doesn't work very well because you're not addressing the immune system and you're not addressing the microenvironment. Now, at the turn of the century, the drugs that many of you are familiar with, the immunomodulatory drugs and the proteasome inhibitors, they work better because not only do they kill the myeloma cells, they disrupt that communication between the myeloma cells and the microenvironment. So they work better. We are currently in the era of immune therapies, which you hear a lot more about, and we're addressing the issue of immune impairment. So you're talking about the CAR T cells and the T cell engagers and the monoclonal antibodies. I feel like I'm talking a bit too fast. I'll slow down. Am I going all right for time?
Perfect. Let me know.
tell me. It's okay. All right. We are now heading towards another era, and that is an era of small molecules. I wish I could have some more time to talk to you about these, but these are exciting, tiny little molecules. They are so small that they can enter into the myeloma cells and disrupt the communications, the signaling within the myeloma cells, and kill specifically just the myeloma cells. So quite exciting times. And you can see that if we combine all these agents together, we are addressing every aspect of pathobiology and therefore inducing a very deep response. And deep response has been shown to correlate with better survival. So if you can imagine multiple myeloma like an iceberg, what we see is only the tip of the iceberg. So if your doctor tells you you've achieved a partial response, it means that we've reduced your myeloma burden by 50%. A very good partial response, VGPR, means we've reduced it by 90%. A complete response means we've gotten rid of the myeloma by the most sensitive test or conventional test, so the paraproteins and the light chains that we spoke about. But even when you achieve a deep response, there's a whole bunch of disease underneath the water there that you don't see. We now have a new level of sensitivity of response that is called MRD, minimal residual disease negativity. And if a person achieves MRD negativity, it means they have less than one cancer cell in 100,000 normal cells within the bone marrow. And so that's very good prognosis. Now, it's not until we achieve 0 tumour cells in the body that we can hope for a cure. We're not getting quite there yet, and hence we're now talking about the concept of operational cure. What's operational cure? So you can see from this diagram here that the deeper your level of response, the longer it takes for the disease to come back. And if you achieve a burden of myeloma down to a threshold, usually MRD negativity, but not necessarily, if you can get it down to a threshold whereby your immune system can take control again, your immune system can keep the myeloma under control for a long, long time, i.e. operational cure. Now, if your doctor tells you that you have not yet achieved a complete response or a MRD negativity, please don't freak out. Deep response is important, but it's not the be-all and end-all. It's the duration of response that is important. So I'm just going to give you an example of this study. This was a study that was done around 20 years ago and with long-term follow-up. And what you'll notice here on the left side is progression-free survival, survival without progression, and on the right side is overall survival. And what you notice here is that after 12 years, notice how the curve is completely flat. Flat means there is no more event. And what this means is that if a person has multiple myeloma and he or she achieves a response, and somehow that response is maintained for 12 years or more, it seems that somehow the immune system can overcome or regain control of the myeloma, and the person lives with myeloma, but nothing happens, like a sort of an MGUS stage. So this is what we call operational cure. Now you notice that while many of those people achieved a complete response or better, there are people in that group with only a partial response who can still achieve the same phenomenon. So therefore, deep response is not the be-all and the end-all, and duration of response is equally important. We're heading towards the end now. So I just want to point out the importance of the immune system in terms of regaining control. And this will lead into Dr. Cindy Lee's talk a bit later on. In healthy people, we know that the immune system should be able to recognise and kill cancer. And this is what protects all of us, you and I, from developing general cancer, even though our cells divide millions and millions of times. So what normally happens is, this concept actually was discovered over 100 years ago, and yet we've only come to do something about it now. So what normally happens is when cancer cells develop, the antigen presentation cells, the yellow cells, the police patrol cells, are supposed to recognise the cancer, eat bits and pieces of them up, present them to the headquarter T cells. The headquarter T cells is supposed to mount a specific attack to that cancer cells. What happens when cancer grows out of control, including multiple myeloma, is that these cancer cells produce abnormal cytokines that corrupt the police patrol. So these police patrol guys are now corrupt. And when they are corrupt, when they eat up the myeloma cells or whatever cancer cells and present it to the headquarter immune T cells, they're saying, hey, this is your friend, not your enemy. And so the T cells think, this is my friend. Oof, I'll go to bed now. So these guys are not attacking the myeloma cells at all. So how does this happen in myeloma? Usually, the headquarter T cells recognize the myeloma cells through a protein or a molecule called MHC molecule, either directly or through the police patrol that I spoke about. What the myeloma cells does, it down-regulates the MHC molecule and it corrupts the antigen-presenting cells. So we now have these headquarters T cells floating around, not recognizing the myeloma cells at all. So how do we overcome this? There are now a number of immune therapeutic strategies, and you have heard a lot about CAR T cells. Sandy's spoken a lot about advocating for it. This is chimeric antigen T cell receptor. So what it is this. This is a man-made construct that consists of two arms. One arm binds to the cancer cells, and the other arm is connected to another arm binding to an immune cell, that's the T cells, to stimulate the T cells. And the idea is that the genetic construct, the DNA construct of this molecule is then created and then inserted into the patient's own T cells. So these T cells, now armed with the instruction, they can now make the cyborg arm, the man-made arm that can only grab to the myeloma cells and nowhere else. So how it works is that we take the T cells outside the patients, and in the laboratory we then insert this DNA construct. The DNA construct then allows the T cells to grow the cyborg arm, and then we flog the T cells and make them really angry and grow them into the millions. And these T cells are now ready to roll. They're going to attack anything that stands in their way. We infuse it back into the patients, and because they've got this cyborg arm, they can't bind to anything apart from the myeloma cells itself. And so that's how they fight the myeloma. There are pros and cons, there are side effects. It's beyond the scope of this talk, but the bottom line is that these T cells can bind to the myeloma cells independent of the presence of MHC molecule. One of the problems with CAR T cells, though, is that it can take months to produce, during which time the person may run into trouble. So there is now an off-the-shelf construct that is competing with CAR T cells that work in similar methods to CAR T cells, and these are called bispecific T cell engagers. And in fact, they are currently competing with CAR T cells. So what is this? This is another man-made construct with two arms. One arm binding to the myeloma cells, one arm binding to the T cells. And what it effectively does is acts as an engager. It engages the T cells to the myeloma cells, bind them both together, and the T cells are now forced to recognise the myeloma cells that it didn't recognise before, and when it does, it can then produce cytokines and kill the myeloma cells. So this is what it looks like under the microscope. You can see the tumour cells in green and the T cells in blue there. The T cells are connected by that tiny little T cell engager there, and you can see the T cells producing a lot of colourful enzymes there, getting ready to inject into the tumour cells and killing it. So that's exciting. In the last 2 minutes, I just want to say one thing about a personalised approach, because we are now entering an era of personalised therapy. Don't read that, it's too complex. But the bottom line is that in multiple myeloma, when we diagnose people with myeloma, we divide people into risk groups according to their cytogenetics, to the genes of the myeloma. And yet we treat everyone the same. It's a one-size-fits-all approach, which doesn't really make sense, does it? And so there is a group of people with a genetic change called a T1114 translocation. About 20%, 1 in 5 people with myeloma have this translocation at the outset. And this translocation predicts for exquisite response to a group of drug called BCL2 inhibitors. So what's a BCL2? A BCL2 is a protein that's present in every cell, and the role of the BCL2 is to prevent the cell from committing suicide. That's it. Multiple myeloma upregulates the BCL2, so it prevents itself from dying. It wants to be immortal. And usually these BCL2 are very strictly controlled. In myeloma, they're not controlled because they're overexpressed. And so BCL2 inhibitors block the BCL2 and thereby forcing the myeloma cells to commit suicide, a process called apoptosis or controlled cell death. And examples of BCL2 inhibitors are venetoclax, and there are now a whole bunch of new second-generation BCL2 inhibitors that are exquisitely effective and, in fact, very well tolerated. And in my last slide, I just want to highlight the fact that these agents are available on clinical trials. Clinical trials are now part of everyday practice in cancer in general, not just with multiple myeloma. And in Australia, while we are so fortunate in that we have the Medicare system and the pharmaceutical benefit scheme that pays for all of us, but because there is a restriction on how much we can afford because we're paying for it, Medicare is paying for everyone, the treatment we have in Australia is good. It's not necessarily the best in the world. It's certainly not up there with the rest of the world. And so how do we access these new agents? We access them through clinical trials. And so oftentimes in clinical trials, you can access drugs that you can't otherwise access outside of clinical trials. So do talk to your doctors because the options are there, and these trials are available around all the tertiary centres around Australia. And so I think I've said enough with that. I'd like to acknowledge all our patients and carers and the team at St Vincent's Hospital and you all. And I'm very humbled to be here, so thank you for your attention.
Thank you very much. That was terrific. Thank you very much, Professor Quach. Did anybody have a question?
Can I have a hug, please?
I think that's fronting up to HR soon. They'll call me up to HR soon at St Vincent's.
Okay.
I just wondered why
Sorry.
myeloma is increasing in the population.
Oh, what a wonderful question. That's good. Why is the incidence of myeloma increasing? I don't think it's anything to do with the biology of the disease, but I think we are now more aware of it. People are now detecting more people with MGUSs, so we're now monitoring people closer. And there may or may not be some environmental factors, but we don't know. And it's increasing not just in Australia, it's around the world it's increasing. Thank you. It is done in Australia. In fact, there are a number of hospitals around Australia that are already testing for MRD negativity. But I want to qualify that by saying this. The reason why a lot of us don't measure MRD negativity routinely is because there's nothing we can do about it because we're limited in what we can give patients. So MRD negativity, it's a prognostic factor. Prognostic means if you achieve MRD negativity, that's great, you're going to do very well. But say if you lose that MRD negativity or you relapse, our options in Australia are so limited in that, well, if we're not going to do anything about it, the cost of doing an MRD negative is like $900 or between $500 to $900. Can we afford to do it when it's not going to change what we do? And the answer is no. In the future, however, we need to push for measurements of MRD negativity because I think it's going to direct care, in a person who achieves MRD negativity, say, for 12 months. Should we then stop treatment? Or should we continue treatment? That we don't know. How it impacts treatment is something we have yet to explore, and there are now active clinical trials around the world, including Australia, to explore an MRD-directed approach. And until the results of those trials come to fruition, we don't know what to do with our MRD negativity, and that is the reason why it's not routinely tested. But yes, it is available.
Thank you very much. And here's a little gift.
Oh, thank you.
And certificate.
Thank you. Thank you very much.
Thank you. Hi, so our next speaker is Dr. Angie Yong. Dr. Angie Yong completed her haematology training in South Australia and a clinical fellowship in multiple myeloma at the Royal Adelaide Hospital. Presently, she works as a consultant haematologist at the same hospital and maintains strong connections with the Myeloma Research Laboratory and the Supportive Oncology Group, both based at the South Australian Health and Medical Research Institute. Angie plays a significant role in clinical trials at the Royal Adelaide Hospital, focusing her expertise not only on multiple myeloma, but amyloidosis and paraprotein-related conditions also. And she is going to talk to us about current treatment options in Australia. Thank you.
Thank you, everyone. I'm very honored to be here. We've got really excellent speakers. You've listened to Hang, she's amazing. Cindy's coming after this. And then you've got me. So I was asked to talk about current treatments that are available, and I was going to, just have a chat about what's available in PBS. But I thought, given that I think with the Australian group, we really haven't had such a big conference before, that perhaps I want to cover just a brief overview of how drugs get approved on the PBS, and just sort of like an insight. So, as Hang has mentioned, the PBS maintains equal access to drugs for everyone with a Medicare card. It doesn't matter what your health insurance status is, which is very different from America. The PBS does cover a little bit more compared to some of our colleagues in Europe, and definitely the PBS funds more drugs than New Zealand. So some of our, our colleagues in New Zealand would struggle to treat with further lines of therapy because it's just not available. It comes as a cost, taxpayers' money, and these are just some of the headlines on the approval of drugs on PBS. So there is, an overview of what's required. So we have research and development, clinical trials to ascertain efficacy. When the clinical trials are done, the pharma company might decide to open an access program before it applies to TGA for listing, and then subsequently PBS listing. Once it's there, specific to South Australia, we then have to add the drugs to a hospital formulary, which can be local hospital formulary and statewide hospital formulary. And this has to go through the local drug and therapeutics committees. There is a lot of paperwork involved with that. Drug discovery, so just a few, an overview. So drug discovery part, 3 to 5 years in a lab. They identify targets. It can be development of an assay that might change the way we pick up things or monitor things, or the generation of some synthesis of potential leads. So that takes 3 to 5 years. They look at roughly 5 to 10,000 compounds, identify 250 just roughly that might be the way to go that they will focus on. Then the next 1 to 2 years is trying to prove the efficacy in vitro, on lab, and in vivo in animal models and preclinical models. From that amount, probably about 5 compounds will be identified to actually be really promising in the treatment of that particular disease. We then start thinking about clinical trials that runs over 6 to 7 years with phase 1, phase 2, and then phase 3 enrollment, which is more multinational, multi-center sites. And after that, that one new drug that's been identified after all these years that has been identified in a clinical trial to be efficacious, then goes through regulatory approval that takes 1 to 2 years. So you can see that from start to finish, it takes about 15 years on average for one drug that was identified in a lab doing research to make it all the way to become something that can be used as a therapy. So research and development are a big thing. We want to support that. So there are government-funded research institutions, so all the university academic associated labs, and then there's also our pharmaceutical companies and industries also have their own research. They're always working. They want to identify new targets, new molecules to treat diseases, to monitor disease. Is there anything we can change the management that will provide a better outcome in that disease stream? So extensive testing is required before that new therapy can be tested in humans. The average cost for one new drug to come to the market based on this JAMA article, it costs about $1 to $2.5 billion before it gets to there. why do we need trials in humans? So one of the really common, we know about the thalidomide disaster. So thalidomide actually was not tested in humans before it rolled out as a drug to combat nausea in pregnant women. It was only tested in mouse studies, and the mice all, the studies were all really fantastic. And you can see that it was a disaster. The consequences and toxicities were just terrible. So this was one of the pivotal trials that started all the ethics and governance approvals requiring drug approvals. And why do we need clinical trials, phase 1, phase 2, phase 3? Phases of clinical trials, as you know, at the Royal Adelaide, and some trials are at Flinders. In myeloma trials, some of our trials are phase 1 trials. Phase 1 trials don't enroll as many patients because they are really just trying to study the safety of the identified compound in a lab that has proven to be really efficacious in animal models. So phase 1 really, you can say that you are a guinea pig, but that's all of the efficacious, all the drugs that are on PBS and all the fantastic CAR-T trials, they all had to start somewhere. So phase 1 is where we start, 20 to 80 participants, not that many, and it can last up to several months. There is it's quite intensive testing because we take blood very regularly to check the levels, make sure the toxicity is okay. We do have a couple of phase 1 trials at the RA. We tend not to have that many. We have more phase 2 and phase 3. So phase 2, you've already had that phase 1 trial. You've had, I would say, preliminary results that showed that it's quite promising. We then go on to phase 2. 100 to 300 participants. It may be different sites now, not just selected sites. And actually, you've established the safety dose, the dose that you cannot exceed. So you're now studying the efficacy. What dose can you give to get a benefit? That takes up to 2 years. And then you go into phase 3, where really there is a lot more enrollment, a lot more numbers. This is multi-site. If we can get it multinational, that is even better. 1,000 to 300 participants. By phase 3, the requirements for blood tests and all this testing of the levels is not as extensive as phase 1. Phase 3, you already have phase 1 and phase 2 data that shows that it's promising. So, a lot of us like phase 3 trials, but we all have to start somewhere. All the good drugs start somewhere. So to me, like phase 1 and phase 2 trials are not necessarily not as good. They just where we have to start to get something new, to get a new target. And then phase 4, we don't do phase 4, but phase 4 really is post-marketing. So if something's rolled out phase 3, phase 4 will be when they publish in the papers, they call it the post-hoc analysis, where they monitor after the trial's finished requirement, they monitor 2, 3, 4 years just to see what the side effects are and what the efficacy is. So the TGA, similar to the FDA in America, this is the regulatory body in Australia for all therapeutic goods, whether it's a device or medicines. Any medication that you're treated needs to be listed on the TGA first. This can take up to 11 months. If it's used to treat serious or life-threatening conditions, it can be fast-tracked. But it's not going to be like a month. What they need to look at is the evidence behind it. They need to look at the research, and if this is a pharmaceutical company developed medication, and usually by the time it gets to TGA, it's got to be because of the amount of investment it goes in to develop that therapy. They need to see the safety data, the animal models. That's extensive. It's like the documents are, it's a lot of data, and they need to assess it first before they say yes, it can be registered on the TGA. Once it's registered, it means that that's the wrong word. It means that it can be used in Australia. It does not mean that it can be accessed, because then you need PBS application. It just means that you legally, if there's a way that you can get it, you are legally allowed to use it in Australia. Once it's registered on the TGA, but not yet on the PBS, sometimes in rare conditions, for example, I'm just trying to think of rare conditions. For example, there are some rare autoimmune inflammatory conditions where it's so uncommon that it's not worth having a registration on PBS for the company to apply and spend the money to register. Then this drug can be accessed using what we call a special access scheme, where these medications can be imported. It's a You have to put in an application to the TGA, and then they would say yes or no, and the pharmacy can buy it in. As of last month, the cost of registration is the new registration is about $270,000 just to register the drug. The annual fee is about $8,700 per medicine. This is assuming that it goes through. If TGA refuses and say, look, we're not sure of the data, we need more, that amount is gone. They have to re-register and try again the next year using that same amount. For the following year, if you need to extend it again, then you have to pay an extension fee as well. So once TGA is approved, sometimes there can be a long delay before it gets listed on a PBS. Then pharma companies often do consider opening an access program. Usually in the hematology, well, we already know about this because we've been paying very close attention to the clinical trials and knowing what's coming, what the data is. And a lot of us want access to some of the drugs. So sometimes when that's done, we want to use the drug. And some pharma companies do open up access programs where we can get the drug earlier before the PBS listing. So when this is done, usually it could be a co-payment scheme where we may have to pay a certain amount and the pharma company will share the cost, or sometimes it's free of charge, depending on what the scheme is. This helps the pharma company to start the ball rolling on looking at data collection, real-world data collection, not just in a highly controlled clinical trial environment where the enrollment criteria is so strict, but real-world market. So this helps them in that sense. It helps us and it helps our patients because we get access to drugs. In South Australia, the number of forms required is crazy. You will notice that I keep harping on it because, for example, like one patient application for me to use an access program would take me 2 hours of paperwork, of forms to fill up, and there could be 2 or 3 different forms, and sometimes they come back and say, you've used the wrong form. You'd redo the whole thing over again. So as I mentioned, the benefit is you get early access to medication, and the company gets a greater number of real-world data on real patients having the medication. We have to report side effects. We have to report any adverse effects to the company because this is part of data gathering. Sometimes the early access programs, sometimes some drugs are not listed on PBS for an indication. Due to various reasons, PBS has refused the listing. A lot of it is economic because, like I said, taxpayer funded. Once it's listed on PBS, there's no restriction, anyone with Medicare card. So we're quite, they are quite conscious of the economic impact of PBS listing. So sometimes we do have pharma companies that can open compassionate access programs for medication that has been proven to use, but just unfortunately not listed on PBS. In that case, then that's also another way we can sometimes access non-PBS funded medication. So for example, although not the case now, but for example, some of you may have gone through every single line of treatment on PBS or myeloma, and then you haven't had Darzalex. So Darzalex as a compassionate access program is available from the company only after you've exhausted every single line on PBS. And that's something that the PBS listing has refused. So this is just, in a way, at least we've got access to it from the company. Jumping through hoops. It's part of the progress. So, yeah. So the PBS, Pharmaceutical Benefits Scheme, I don't have to go to too much, but you guys know about it. I was giving this to an international talk. So basically, medications are all, anything on PBS is available to Medicare-eligible patients with whatever restrictions that they got on there. It's subsidized at $30 for general patients, and for concession is $7.30, which is really great considering some of the costs of the drugs are quite high. So in 2019 to 2020, on PBS medications, it was about $12 billion spent just based on that subsidy that they've spent on. So, there's a fair bit of investment in Australia to improve the healthcare. And I think we can appreciate that because even though we are not, we don't have CAR-T, we don't have other, we have so many other things that a lot of other countries don't have. And we don't need health insurance. So that's that trade-off. So how does a drug get listed on PBS? So the PBAC will evaluate all submissions provided by the pharma companies or an individual organization, though that is usually not as common because it requires extensive research data and the financial cost involved in trying to apply to list the drug is quite high. So they look to see if new medications are appropriate for listing, if existing medications, some of the medications can have restriction. If that restriction can be removed, the PBAC would review that. Typical submission costs. So for myeloma, usually the drugs are category 2. So just to apply to PBS, for PBS listing, as of last year, it was about $200,000 just to apply. If that's turned down or they come back and say, looks promising, but you need to submit data on blah, 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 you spend another $200,000 to resubmit that. There's also pre-submission meetings where there's some initial discussion about whether these are worth it, and that's probably another about $50,000 to $70,000, and depends on how many meetings. So, to submit a drug, it's not cheap. There's a lot of cost and work involved. So overview of process, so there's a pre-submission requirements with the meetings. There are the lodging submission. You have the procedures, the evaluation, the input on the applicant, which is the company, and then this part where you always see, Myeloma Australia will send you emails to say, oh, consumer input, please email about this. That is where this comes in, consumer input, and then additional clinical input. A lot of the times with myeloma drugs, they will ask the MSAC, the Myeloma Scientific Advisory Committee, on what their input is on this drug. Usually the MSAC is very proactive in providing input into approval of new drugs onto PBS. So they'll get that, and stakeholder meetings as well. And then there are all the other resubmission pathway post-market. So if you do want to have a look, this is all available on PBS website, and you can, if you are interested. I think there's a lot of other things to do. So I was initially asked to talk about current treatments in myeloma and the newly, and I found this really hard because I didn't know what to say. To me, treatment should be individualized. It should be personalized. It should depend on how you are doing, what your comorbidities are, where you're living, and what we can do, and what's the best treatment in that context. So I thought, look, I'll just put a brief overview of the side effects, but usually when I talk to someone about treatment, that takes me 1 hour. So this is not going to cut it. So this is just a snapshot. Currently, what we tend to give for newly diagnosed myeloma, it's a combination of 3 drugs. This is current practice. Bortezomib Velcade, which is an injection under the skin, lenalidomide tablets, and dexamethasone, which are steroid tablets. Okay, it could be it could be all 3, triplet therapy. It might be a doublet where it's only Velcade without the lenalidomide, or it could be lenalidomide without the Velcade. It really depends on the presentation and on, like I said, your other health issues. Newly diagnosed, this may include radiotherapy. If you've got a painful lesion, radiotherapy does target that area a bit faster. It doesn't cure, but it targets faster so that at least we can try and get on top of the pain and discomfort that you're feeling. Or radiotherapy sometimes could just have enable faster treatment around that area because you might have a lesion that's at risk of a fracture, and we're hoping that if we get to that part quicker, that would just try to stop the lesion, the myeloma lesion in the bones there from getting worse before the improvement with systemic, with all the treatment that you're getting can kick in. In some people, an autologous stem cell transplant is what we recommend as first line. And then after that, there's maintenance therapy. I just wanted to say, if you watch this space, perhaps in 5 years, this climate might change. We may not be recommending autologous stem cell transplant now that we've got so much research, so much trials on CAR-T. We're trying to see if we can do with autologous stem cell transplant, but not yet. I think this is 5 years down the road. So this is a treatment for newly diagnosed. For what it's worth, we can cover this. So bortezomib, which is also known as Velcade injection under the skin, is not affected by kidney function. The major side effects that we tend to be really worried about are Velcade, the neuropathy, burning pain, which doesn't affect that many people, but when it affects it's really painful and a pain in the ass and it's disgusting and you feel terrible. So we must always let your clinician know if you've got any numbness or tingling. And I try to ask, but sometimes, forget. Sometimes neuropathy doesn't cause numbness and tingling as the obvious symptom. Sometimes people get nerves that regulate your blood pressure. Those nerves are affected. So autonomic neuropathy is one of the symptoms where if you sit down and then you stand up, you suddenly get very dizzy because your blood pressure is not as regulated because those nerves are affected. So that can be quite an uncommon neuropathy presentation. So that's bortezomib. What it does, it tries to block the protein that stimulates the myeloma cell. So it's trying to reduce the myeloma cell and increase the death of myeloma cells. Lenalidomide, which is also another a derivative of thalidomide. It's a tablet, it's easy to take, but there are side effects. So risk of clots, any of the immunomodulatory drugs, thalidomide, pomalidomide, lenalidomide, there's a risk of clots. In clinical trials, this has been noted with thalidomide and dex combination. In subsequent clinical trials, everyone who received lenalidomide had to take at least an aspirin, if not a blood thinner. So whether this risk has reduced with with lenalidomide and pomalidomide, which is a newer IMiD, we don't know because none of us are brave enough to give you those tablets without putting you on something to prevent clots. But clots risk is a risk. Sometimes you take the tablet and you could be fine for 3 to 4 years and something happens. Maybe you've had a knee operation, maybe you've had a long haul flight and then you had a cold, so you were bedbound for 2 days and that's enough. Bam, clots. So we always have to be aware of it. If you have leg swelling, one leg that's swollen or you're short of breath, then always we're like, is there a clot there? Lenalidomide does require good kidney function. So it may not be suitable in people with kidney issues. And diarrhea is well known. I think we've reported a lot of diarrhea. You can see it. That's usually not immediate. It's usually after people have been on lenalidomide for a while, and it tends to be like a late-stage manifestation. Again, that one really is a pain in the ass when it happens. And one thing about lenalidomide, similar to thalidomide, causes birth defects. So I know may not apply to many of you here, but we always have to be careful, and we all have to register with the Pregnancy Risk Prevention Program. Even if you're 85, we have to do it. Viagra works wonders. Okay, I have to rush. Okay. We know about steroids. I'm not going to talk much about that. It can be very difficult. You can get shaky. It can cause your blood sugars to get worse, and side effects. Now, hold on. So transplant, like I said, I spend 1 hour talking to a patient about first-line treatment. There's not enough time. So quick coverage on what is available now for relapsed refractory myeloma. We've got, all these lines here. And this is much more than what we had compared to 5 years ago when I first started my myeloma clinical fellowship, and much more 10 years ago when we've just talked about melphalan. I have an asterisk next to daratumumab, bortezomib, and dexamethasone DVD. A lot of you now, the newly diagnosed, may have had this if you have had the first relapse. And this is because of a PBS requirement that daratumumab can only be used in this combination with bortezomib, regardless whether you've had neuropathy or not, and it can only be accessed in first relapse. If we don't use it then, and you use the other drugs, you cannot access daratumumab anymore. So that's why we are restricted by what PBS gives us. And there are also clinical trials available in relapse, which Cindy will talk about later. And also, I've heard that this combination, carfilzomib, lenalidomide, and dexamethasone, has been approved, and it's coming. So you can add that to the mix. Eeny, meeny, miny, mo. Can I skip? Okay, because I've got 1 minute left. Okay, sorry. Okay, but the main thing I wanted to say is one size does not fit all, even though that's what PBS has given us. They've put requirements on there, but really one size doesn't. We are restricted by what PBS says we can have, but I feel that the treatment we give should be personalized to your diagnosis, and Hung did touch on it a little bit with the cytogenetic risk. We are not at that stage where we can use the cytogenetics associated with your myeloma to tell us what therapy. We are not there yet. But that's what we are looking at, to see whether we can, certain treatments are better for certain mutations. That's probably going to be in the future, but we are not there. So what I like to say is it's personalized to you. If you're from the country coming, some of my patients live in Cooper PD, which is quite far. I can't get any Velcade there. There's no way. So what can I do, depending on the discussion, for them to still have myeloma treatment, but still have a good quality of life? And that to me is the main fundamental of treatment is I want you to live longer, but I want you to have a good quality of life, not live longer in pain with neuropathy. That's not the goal. So we just need to make sure that whatever we do, it's discussion, right? What PBS gives us, what we think might be a best next few options, and what you think you want to have. Any questions? I did tell some of my patients, I said, you're not allowed to ask me any questions today.
They're also well informed.
Oh,
You've covered everything.
very good, very good. I did want to do a survey. Do you know if I could? I did ask for a poll. Do you?
Yeah, sure.
Never mind, I'll do it this way. So, can I ask, maybe show of hands if that's easier. Now, I do a lot of collaborative work with SAMRI, and one of the supportive care oncology group, we've been talking a while about trying to get some research and some looking into lenalidomide and diarrhea. We don't know enough about that. There has been 2 publications, one only in 2014 saying that it could be due to some bile acid malabsorption, but there really hasn't been much else to tell us why lenalidomide causes diarrhea. Lenalidomide is the only treatment at the moment that's approved for maintenance after stem cell transplant. So I think diarrhea is shitty, affects your quality of life. How many of you, can I just get a rough estimate here, how many of you have been treated with lenalidomide and or currently receiving treatment with lenalidomide? Hands up, and I can, how do you hands up? That's it. You say 80%? Yeah. Okay, thank you. Second, ooh. It's okay, I think we do it like that because it's faster. Otherwise, if you ask me to do this, I'm going to take 5 minutes. Oh, how about my next question? Oh. I'll just say, good job. Took me a long time. Do I go next? Or? Yes, and have of those that have had lenalidomide, 80%. Oh, okay. How many of you have had diarrhea with it? And this is more so that we can use it as a phase 1 saying there's interest and we can try and get some grants to look at this. 20, I'll say 20. I'm just going to scribble. 80%, 28. And I think there's one more, last question. If we can come up with a survey about lenalidomide diarrhea, would you be interested in participating in it? Yeah, okay, good. And that's it for my talk. Is it morning tea? Okay, thank you.
Okay, thank you very much, Angie. I think that was great. It's always really interesting hearing about how drugs actually get to market. It's so hard. So thank you for explaining that and giving us a brief overview of all the agents we have. And here's a small gift. And thank you very much.
Thank you so much.
Thank you.
Thanks.
Okay, so today you're hearing from some really excellent speakers from around Australia and particularly here in South Australia, but our next guest hails from New York City, which she likes to distinguish from the rest of America. We talk about rock stars in myeloma, and we have a lot of medical rock stars in myeloma, but our next guest, Donna Dr. Donna Cadamero is a nurse, and for us myeloma nurses, she is a true rock star. Donna is a nurse practitioner in multiple myeloma program at Mount Sinai Hospital in New York City, and she's worked as a clinical research coordinator in Boston and was given myeloma studies to work in. She enjoyed learning about the disease and working with patients so much she decided to become a nurse, and she moved to New York City and started working in an oncology unit where a new physician from Arkansas had just started and who was building a new myeloma program, another rock star in myeloma. After a year, Donna moved into the myeloma program full-time as a research nurse and eventually studied to become a nurse practitioner. 20 years later, and Donna continues to work with the same physician. They must get along well. Over the years, she's seen sweeping improvements made in treatments, overall survival and quality of life, as Angie alluded to, and in the innovative treatment modalities that are being used to harness the patient's immune system to kill off myeloma cells. CAR-T therapies and bispecific antibodies provide patients with deep and durable remissions. Donna has patients 15 to 20 years from initial diagnosis who are doing extremely well. It's very exciting. What Donna enjoys most about being a nurse practitioner in myeloma is the ability to improve patient outcomes and quality of life. She is part of the International Myeloma Foundation's Nurse Leadership Board, where she can contribute to the discussion around treatment and supportive care guidelines for patients. Being part of the foundation has been a highlight of Donna's career. So welcome, Donna. We are delighted to have you come and join us.
So thank you. This is such an honor to be in Australia to speak with you. And I know that I'm standing between you and lunch, so I will not. I have my watch on, so. And actually, this slide just shows you where we're situated in New York City. We're at the top of Central Park. And it's a very diverse neighborhood. You can see Central Park, and those houses along that street are millions and millions of dollars. But on the parallel street is low-income housing. So we really have a diverse patient population. So today I want to talk to you about supportive care, symptom management, and then new emerging treatment options right now that are available, clinical trials in Australia, but coming soon, and it's really changing the landscape of myeloma treatment. And then I want to just turn gears and talk about how I can encourage you to engage in your healthcare making decisions so you're part of the team, and then ending it off with healthy lifestyle. The healthier you go into treatment, the better your outcomes are. So there are symptoms from treatments, but there are symptoms from myeloma. So myeloma, the main symptoms, we see bone damage, renal insufficiency, kidney damage, and low blood counts. So bone disease. The majority of myeloma patients will experience lytic lesions, bone damage, and what myeloma does is it punches out these holes in the bone. It can also lead to osteoporosis or osteopenia. And then, fractures are very common with myeloma patients. So how do we manage bone health in patients? So there's a class of drugs that we use, biphosphonates, and it makes the surrounding bone stronger. So you're not going to grow new bone, but it's going to fortify the bone that is not damaged. So it will make it less likely for you to have a fracture. And this is all our patients are on this in the States. Patients who receive biphosphonates have better outcomes. But there are side effects, and there's always, a little good, a little bad. Something before starting these bisphosphonates therapy, so Zometa is probably the most common one that we use, even though it strengthens bones, but there is a significant side effect called osteonecrosis of the jaw, which seems counterintuitive. It actually breaks down the bone in your jaw. So prior to initiating these types of treatments, I make sure that all dental work that is needed is complete. So if there are any dental extractions or teeth that need to be pulled, that needs to happen before I even initiate treatment. So all dental work needs to be complete, but this isn't cleanings or cavities. This is when a tooth needs to be pulled. So we want all that work done before I initiate treatment. and then good dental hygiene while on treatment. With lytic lesions and bone disease comes pain. If pain is isolated to one area, we can zap it out with radiation, and this can provide quick relief for patients. But other management for pain is usually medication driven. So I just learned yesterday you don't have Tylenol, you have Panadol, which is good for pain, but maybe doesn't really relieve many myeloma patients' pain. NSAIDs, nonsteroidal anti-inflammatory drugs, so ibuprofen drugs, are good for treating pain, but not good for the kidneys. And so we know that myeloma can damage the kidneys, so anything that can damage kidneys or compromise kidneys, I want to avoid those. Opioids do provide good relief for pain, but can have some side effects as well as fatigue. There is constipation with opioids, but also there is a risk for addiction. And then steroids. So steroids are great. It's not something I would want to do long term, but that can also help manage the pain short term. And then for neuropathic pain, neuropathy, there are drugs that can help. Fortunately, with neuropathy, there is not a silver bullet that I can give a patient that will get rid of the neuropathy. So this is more challenging pain to treat, but there are drugs such as gabapentin or Lyrica that can help manage patients' neuropathic pain. So other effects of myeloma can affect the blood, so lowering of the red blood cells, which causes anemia, which patients will often report as fatigue. So if you are anemic, it's also important to rule out any other causes for anemia. So patients can have vitamin B deficiency or iron deficiency, and that I can easily fix with supportive care medications. So we want to rule out other causes. Low white blood counts, this puts you at high risk for infections, and infections we'll talk about a little bit later. It's for myeloma patients, you're already at high risk, and the treatments we give, the disease, it's a bad combination. So I look at your white blood count. If I see that it's low, I might put you on antibiotics prophylactically, or give you some medication and injection to boost up your white count. And then platelets. Patients with low platelets are easily for bleeding, bruising, so that's something I monitor, and we usually do transfusional support if they are extremely low. So I talked about the kidneys, so about 18% of patients present at initial diagnosis with renal insufficiency, so I want to make sure I protect those kidneys. And what happens is that myeloma protein clogs up the kidneys and it can't filter out because the kidneys are our filter system. So it really can damage the kidneys. Again, I look for other causes. So hypertension, so poor control of blood pressure can lead to worsening kidney disease. So I want to make sure your blood pressure is well controlled as well. And then all patients should really maintain an adequate fluid intake. So 2 liters of fluid a day really makes the kidneys happy, so please do that. And then other medications, like I said, the ibuprofens can harm the kidney. So if you're starting a new medication, run it by your myeloma doctor. Make sure it's safe for the kidneys to take. But then other things that myeloma treatment, so the treatment we give, can cause significant side effects. We talked about, the speaker before me, about blood clots. So yes, the treatment we give can lower your counts, but it can also put you at higher risk for blood clots. Peripheral neuropathy we spoke about. Actually, sometimes it's caused by the myeloma, so a small percentage of patients at diagnosis before they get even 1 drop of treatment actually have baseline neuropathy, and that's due to the myeloma attacking the nerves. And this is very hard to manage, peripheral neuropathy. Cardiovascular, so there are drugs that can affect the blood pressure. So if you're already on medication to maintain your blood pressure, I might need to add in a second medication to provide you better control. And then gastrointestinal, so diarrhea, constipation, can be very problematic and affect a patient's quality of life. So I want to separate the medications we give out by drug class. So Revlimid and Pomalyst, so we talked about blood clots. So you'll be on a low dose aspirin. But if you decide to come visit me in New York, which I'm open arms to everyone, that's a 22-hour flight. A low dose aspirin is not going to cut it. So you're going to have to be on something a little bit stronger as well. So it depends what your risk factor are. If you're a little more overweight, that increases your risk for blood clot. Being sedentary puts you at higher risk. And so I would say any flight over 3 hours or a long car drive where you're sitting for long periods of time is going to put you at risk. Talk to your team, and I can temporarily give you something to provide protection, especially for travel. Pomalyst, similar side effects, but this can make patients a little confused. So I would dose in the evening, so you're sleeping through any confusion. Proteasome inhibitors, so Velcade is a drug that we give usually with newly diagnosed peripheral neuropathy. So still a third of patients report peripheral neuropathy with Velcade. It's important to tell your team as soon as you're experiencing symptoms. I'd never want to get it to the point where you're walking staggered. Sometimes the neuropathy can be permanent, and I never want it to get that bad. You should be able to button a shirt. You should be able to put on your shoes. You should be able to walk down the hall. Please inform us. That might require a dose adjustment with the Velcade. And then also with Velcade, I see patients alternating with constipation and diarrhea. So we do have medications for both. You need to let us know, because again, diarrhea can affect a patient's quality of life. I'm in New York City. Patients take the subway to come to their appointments, and they don't want to have an urgent need for a bathroom in the middle of a subway station. It's New York City, though. People do what they want. Kyprolis is a second-generation proteasome inhibitor, less neuropathy, so better tolerated in that aspect, but this is where we can see the fluctuations in your blood pressure. So if you're already controlled on one medication, you might need that second medication. So I want to make sure that your blood pressure is well controlled before I even start, and then I'm going to monitor you throughout. And then you want to report any shortness of breath while on this drug, because that could cue me into something maybe cardiac-wise that is going on, and I want to monitor your heart. So monoclonal antibodies, I know daratumumab or Darzalex is used here in the second line in combination with Velcade and dexamethasone. This drug is now an injection. Before we used to give it as an IV infusion. With that injection, we see less administration side effects. So when we gave it as an IV, half the patients would have a reaction with chills, shortness of breath, and we'd have to stop the infusion and manage the patient. With this injection, very little adverse effects. So about 9 to 10% of patients may have a reaction. It's usually respiratory in nature, so you might feel a little short of breath. We give you medication before we even start with the injection. And then the first few doses, I'll give patients post-steroids, because sometimes those reactions can be delayed and patients might get that shortness of breath or wheezing. So we give patients steroids to prevent that. Overall, Darzalex or daratumumab is well tolerated, but it does put patients at higher risk for infection. So that's another, myeloma is one shot against you, and then the drugs we give you also can cause that higher risk for infection. And that's where patients get in a lot of trouble with infection. And we'll talk about how we're going to manage that. Expovio or selinexor is new to Australia. I believe it was approved in May of this year, and that's in combination with Velcade and Dex. This drug works well, but it does cause significant nausea. So we are going to give you medication, and it's usually at least 2 medications to control the nausea, and it's important to be compliant with those medications to really prevent that nausea. If needed, we might need to add in a third agent to control the nausea. So that's good communication with your team, letting us know how you're tolerating this drug, because I want to get on top of that nausea, because significant nausea can lead to decreased eating, which can lead to weight loss, and I never want that to happen. So good communication with us, staying hydrated, and that nausea control. So I just want to change gears and talk about some exciting treatments that are in the horizon. They're currently approved in the United States, but I think very soon here as well. So CAR T treatment, and you'll hear more about this afternoon. Right now it's available on clinical trial only, but this is a very novel approach. So we take a patient's T cells. So T cells are part of your white cells, and they kill any foreign invaders, so infections, but also cancer cells. So we take the T cells out of a patient, we genetically re-engineer them to target the myeloma cell. So it's like putting a little GPS in your T cells, so now your T cells know exactly where to go. So this is using your own immune system to fight off the myeloma cells. But with any novel treatment comes unique side effects. There is a release of cytokines, and I'll talk about what that implication means for patients. But this is a process. We have to take this T cells from a patient, and then they have to be manufactured. And from what I'm hearing, that manufacturing is taking place in the United States. So in the United States, usually it's about 4 to 6 weeks, more like 8 weeks. So it could be even longer for Australia because those cells are coming back to you. So that could be potentially 2 to 3 months that we're waiting for those cells. But I don't want a patient to be off a treatment for 3 months. So I often give a patient what I call bridging therapy to hold their disease at bay while we're waiting for those cells to be manufactured. Once those cells are ready, I'm going to give my patient more chemotherapy for 3 days to kill off their existing T cells to make room for the new T cells. And now those T cells are going to be infused. It's a one-time infusion, and I think of it as a living drug. So patients will get this infusion, and their immune system is constantly fighting the myeloma cells. So with these therapies, I'm going to talk about what cytokine release syndrome is. Neurotoxicity is a potential but rare side effect, but infections. So patients on these therapies are even at higher risk for infection. So I have to be more prophylactic and to make sure that patients are not getting infections. And actually we're seeing more patients have more serious complications from COVID infection with these types of therapies. So again, it's only available on clinical trial, but I think within the next few years it should be more widely available. It's highly effective. So in clinical trials, we're seeing patients with a 98% response rate. So almost all the patients are responding. And these are deep, durable responses. So I have a patient 8 years out from their CAR T therapy who had multiple lines of therapy, multiple relapses, and now has been disease-free for 8 years. So these are, like, I would think the Rolls Royce of treatments, not available yet wide, even in the US, but hopefully I think the wave of the future is coming. I did say that there is some neurotoxicity involved, so we do recommend patients not drive for 2 months because that neurotoxicity could happen after a patient is already discharged from the hospital. And that's why caregiver support is crucial, because if you're experiencing confusion, you might not realize that you're confused, but your caregiver will. So having someone with you who can care for you is essential for the success of this treatment. Next are bispecific antibodies, and these are the new kids on the block. And the mechanism of action is very similar to CAR T, but there's no manufacturing. So this is a drug similar to daratumumab or Darzalex, but now it's attaching to the myeloma cell, but also attaching to the T cell. So one arm grabs the myeloma cell, the other arm grabs the T cell, brings them close together, and you have the same effect. So it's mimicking CAR T, but this is a continuous treatment that patients are on, could be indefinitely. Again, patients respond well, so 7 out of 10 patients will respond, or 70% of patients respond. Cytokine release syndrome is also, so the same side effects we see with CAR T, we're seeing with bispecifics, but this is usually with the first few doses. After that, patients tolerate these treatments very well. Right now in the US, we have 3 drug approvals. They all came within the last 8 months, and we had the last 2 drugs approved within 3 days of each other. So it's been a wealth of treatment options for patients. And I like this because this is off the shelf. If I need to treat a patient now, I can start a patient on treatment, whereas with CAR T, it could be several weeks before I get that product to the patient, and it's more involved to process or to manufacture cells. Yes, cytokine release syndrome. The bispecifics that are currently available in the US are injections. So with any injection, we can see skin reactions. Also, again, infection. These patients are at even higher risk for infection. So patients need to be prophylaxed with antibiotics. We monitor their healthy IgG levels. If they are low, which they will be on these treatments, we are supplementing patients with IVIG, and that's on a monthly schedule, and that's going to provide them with some protection against infections. So you heard me talk about CRS, cytokine release. So with when we're manipulating T cells, we have a rapid, large release of cytokines. Cytokines are little immune substances that are released and can cause a little bit of havoc on with the different body systems. The hallmark sign of cytokine release is fever, and it's typically low grade, so 38 degrees Celsius, and that's why, for the most part, these treatments are done on an inpatient, and for bispecifics, we're doing the first few doses inpatient, and then after that, patients can go home. The risk period for CAR T, it's anywhere, depending on the product, could be 1 to 9 days, and usually patients are in the hospital for at least a week with CAR T, and then with bispecifics, it could be up to 10 days. Again, giving them, if they do have CRS, they'll be in a hospital setting, and we can intervene. So typically, CRS will start off as a fever. It can progress to low blood pressure or difficulty with shortness of breath. The institutions that are administering this treatment are well trained, and the majority of patients are getting fever. We intervene and reverse it. So a patient described what it's like for CRS. If you've ever had the flu shot, the next day you get a little achy with the low-grade fever. That's what patients are experiencing. So I would say overall tolerable, but there is a small likelihood that it could progress. So neurotoxicity, what is that? That can present as a headache, some confusion, tremors, and again, this is very rare. It can happen simultaneously with CRS, but more likely it happens after CRS, and then it could happen after a patient is discharged. So again, that's why I say caregiver support is crucial. This is reversible. We manage this with steroids, and we don't see any long-term complications. So infection. So these treatments that we give put patients at high risk. So just having the diagnosis of myeloma, you're at 10-fold increase of infection. Now I'm giving you treatment that puts you at even higher risk, in that drugs that actually target what we call BCMA puts patients at very high risk. So I have to monitor these patients, so any type of fever, that deserves a phone call to your team. We need to intervene right away. And as I was saying, COVID has been very problematic for our patients on these types of therapies. And we're seeing both viral and bacterial infections. And a third of patients have serious infection. And so what is a serious infection? Needing IV antibiotics or a hospital admission to treat their infection. And COVID is more serious in these patients. So any type of COVID symptom, call, test, and then we give patients Paxlovid right away at the first symptoms. So prevention, we talked about IVIG for patients on these drugs. Immunization, so vaccines, and in the US, vaccines unfortunately now has a stigmatism to it, but they're so important for patients. So seasonal flu vaccines, COVID vaccines with boosters. A new booster is coming out in a few weeks. I recommend everyone getting it. RSV was another respiratory infection that was very common in our patients. We finally have an approved vaccine in the US, and it will be more widely available in the upcoming weeks. So please be up to date with your infections, because if anything, infections is what really gets patients into trouble. And then changing gears again, more side effects that we deal with. So dexamethasone is usually the backbone of every treatment we give, and it literally has the most side effects, from sleep disturbances, insomnia, weight gain, mood changes, increased appetite. So understanding all these side effects, working with your team, we can sometimes titrate the dose so that you can better adapt to these changes. Constipation and neglected diarrhea, but we do have a lot of supportive medications that we can give patients for constipation, laxatives or stool softeners, and for diarrhea we have antidiarrheal medications. And for patients who are on Revlimid maintenance, usually patients get more diarrhea after their transplant, and that's when they start seeing their first really bad diarrhea symptoms. So we can hopefully help you manage that. You have to let us know and feel comfortable talking about it. Acid reflux, this really ties in with steroids. We do have medications that we could give. I don't want to do this long term because there's other problems with these medications. So usually when we do dexamethasone, I tell patients they need to take it with food to try to avoid acid reflux. We talked about insomnia with steroids, good sleep hygiene, don't take your phone to bed. I know my bedtime, I want it to be 10, but then I take my phone with me and next thing I know it's past midnight. So try to keep your electronics in a separate room. And if it's really affecting you, there are medications we can give to help you sleep. And then I really encourage you to be part of the decision making. You should never be told this is what you're doing without a conversation with your team. So you know yourself better than anyone else. And you really need to engage with your team and know who the team members are, from your nurse to your social worker to your physician to your general practitioner. And this really lays the foundation for a good relationship, empowers you to make those decisions, and really advocate for yourself. Voice your goals. What are you looking for in a treatment? These are my goals. I prefer something all oral. I want to maintain a job. I can't go back and forth for treatments. You need to let us know what your goals are, what your priorities are, and we can kind of titrate your treatment around your lifestyle. And then finally, healthy living. I get asked a lot about diet. I don't think anyone should ever deprive themselves. I have patients who avoid sugar at all costs, but everything in moderation. Donuts can make people happy. So, I'm never going to say no, but, healthy weight, the healthier you go into treatment, the better that you're going to come out of it. So usually when someone is frail, they don't do as well as someone who is fit. So healthy diet, exercise, and I'm not talking about running a marathon, but I'm talking about going outside and walking every day, getting the body moving. These are all good things for a healthy lifestyle, and in the long term, patients do better. And then don't forget about other things. When patients are diagnosed with myeloma, they forget about everything else. Don't forget your colon screenings, your breast exams, prostate. Other things can happen, so don't neglect your other healthcare needs. So this, I believe, is my last slide. So you want to make sure you talk to your team, tell us your side effects. We can often manage them, but if you don't tell me, I don't know, and I don't want you to suffer we can work through this. So with that, I want to say thank you, and I'm so honored to be here, and I'm a part of a bigger team at Mount Sinai and couldn't do this without them. So thank you very much. And I don't know if I have time for questions.
Any questions? You're all raring to get to lunch.
I know, that's the problem of being before lunch. I will be around. You can always pull me aside and happy to answer questions. Thank you.
Okay, thanks, Donna. She's running away. She's running away. Okay, just a couple of things before you go. The lunch is going to be in little boxes, so please feel free to bring them in here or mull around in the foyer out there if you like, and really encourage you to get about and have a chat with one another and chat with the nurses. And Donna said she'll be around, so that's another good thing. And we also want to highlight the company that make the CAR Ts here for our Australian myeloma population are putting another submission into MSAC, which is kind of like the PBS, but more on the technology side. And we would really encourage all of you to put in some comments about how important these emerging therapies are for you guys. On our website, we've just uploaded instructions on how to do it and some tips on how to, I guess for a better word, communicate to the MSAC committee how important these research, etc. is. So if you could do that, that would be great. Otherwise, enjoy your lunch, and if you could all be back here by 1:30, that would be fantastic. Okay, thank you.